Hernia is essentially when the muscular or the tough content becomes weak and a hole develops, and then the contents of that structure are able to emanate through the gap. So, the example being in the abdominal wall, we develop a weakness or a hole in the muscular wall, and then perhaps some of the barrier or the intestine or the fats within the abdomen is able to emanate through that hole, causing a visible swelling or pain in that site. So there are various hernias that can affect the anterior abdominal wall in the grain, and starting from the top, the first one is known as epigastric hernia, and this gets its name from the anatomical region situated between the breastbone and the belly button, which is known as epigastrium. And often these are situated in the midline where we develop a weakness called a small hole in the anterior abdominal wall, and then usually, some of the fat within the abdomen is able to protrude through that hole, through that gap, causing a small bulging hole. And in the epigastric region, it is sometimes referred to as a ventral hernia. That's a term which is interchangeable with epigastric. Then we have hernias in and around the belly button. One is that we are born with are known as umbilical hernias, and one is that we develop during adulthood, just to the side of the belly button are known technically as paraumbilical hernias. Then moving down into the grain, there are two types of hernias affecting the grain. There is inguinal or inguinal, and small hernia, which is just below the grain crease. The other type of hernia that we can see in somebody that's had an operation, where there's a scar with, there can be a weakness that develops within the scar leading to a bulge. And that is known as an incisional hernia, which is simply a consequence of a preeclampsia surgery and scar. The one type of hernia that warrants a mention, although it is not a hernia of the anterior abdominal wall or the brain, is known as a hiatal hernia. And this is something that's often diagnosed during a gastroscopy where we are doing a fiber optic assessment through the mouth, the esophagus, and if the stomach is when we see a weakening in the diaphragm muscle as those figures go through diaphragm into the abdominal cavity. If that passageway is weakened, some of the stomach can ride up into the chest and actually sit within the thoracic cavity. So that is a definite hernia, but it's quite a complex type of hernia. So brain hernias can present either in childhood, whether it's a congenital or that simply means a defect in a muscle that we are born with, or as we here and there, as we get a bit older. We can develop the weakness in the abdominal wall, presenting in our 20s, 30s, or beyond. The type of individual that would be prone to hernias are several. If somebody is doing a lot of heavy lifting, either manually balanced, whose that job would be lifting heavy weights, or people lifting heavy weights in the gym, people who are putting chronic strain in the abdominal wall, such as chronic coughs, people with asthma, bronchitis, bad hair fever, constantly coughing, sneezing, patients who have chronic constipation, or men with inadequate prostates who may need generate forced pass urine. Chronic cough during smoking, all of these put a little the increased strain in the abdominal or musculature other post people who don't have those. The greatest presentation of a hernia is a visible lump either in the grain or indigenous of the abdomen that will describe. The patient will normally notice this in the shower or bathing, or when they're getting dressed and they see a lamp that wasn't there the day or the week before. Sometimes it can be slightly more obscure than that. There may not be an obvious lamp, and the patient may describe a sensation or a dreading sensation or a pain or just a localized phenomenon that wasn't there the week or the month before. And the doctor may not even feel a lump at that stage. These are the ones of a type of hernias that can be difficult to detect in the clinical setting and may require a test or an investigation to confirm the diagnosis. These lumps will generally be more obvious when the patient is standing or straining and will usually go away when the patient lies flat. So you can have a small hernia where the actual hole in the muscle is quite small. That is disproportionately painful, and you can have a rather large grain hernia feeding the scrotum, which doesn't cause much of the symptoms at all. But as a rule of thumb, as the years go by and hernia or gets bigger, they will generally be symptomatic. But again, The procedure depends on the patient. Is a physical condition. Patients shouldn't be classifying the hernias and then looking up the default management of that. I'd prefer patients to either go directed to a specialist at FFL to correct their GP examine and make a relevant referral if necessary. Because as I've said, not only if patients choose not to seek medical help, they have to live with the symptoms that hernia producing on a day-to-day basis. They may often, if patients have been living with hernia for many months, they would have stopped playing tennis or golf or whatever it is they enjoy doing. Their hobbies and questionable have been put on hold. So why not just get a professional opinion? Are hear from the horse's mouth what is the correct way of managing this, and if appropriate, a short way, minimal invasive repair by surgeons after all their profession.